Thank you, Osman, and good afternoon, everyone. I'm really pleased to be here. As you mentioned, I have really two, passions, work-related, technology and One Health. So I'm really excited to be chairing this really interesting session. So just quick points. Each speaker, we will have 3 for this session. We'll have 10 minutes to present their work. I will inform all the speakers when there's 1 minute left for the presentation, so you can wrap up. And then at the end, we will have a Q&A session. So I really encourage everyone to pose your questions there, and then we will try to answer as much as possible during this Q&A session. So let me start with the first speaker, that's Mercy. Mercy is an epidemiologist with over 10 years of experience in strengthening health system in detecting and responding promptly to public health threats. She currently leads the event-based surveillance program of the Africa CDC, which is supporting the establishment of early warning system to improve early detection and reporting of public health threats in the African Union member states. Mercy also doubles as the focal information exchange with the Africa CDC, where she leads the development and operationalization of the AU Health Information Exchange policy and standards for health system in Africa. So please, Mercy, the floor is yours.
Thank you so much, Laura, for this opportunity. And colleagues, it's a pleasure to be here presenting on One Health early warning and response system tools. So quickly, I'm going to start by looking at what early warning and response means. And we'll also be able to appreciate the importance of One Health in achieving early warning and response. And then we'll go further to look at how One Health can be applied in achieving early detection. And finally, look at the different tools to consider in this process. Next slide, please. So, colleagues, as you can see on the screen, early warning refers to the organized processes to collect and report data from a range of different sources in order to detect public health threats. And these sources are mainly the event-based surveillance sources and the indicator-based surveillance sources. Next slide, please. So event-based surveillance actually is a component, a very critical component of the early warning and response system. And it's mainly just the organized collection, monitoring, assessment, interpretation of mainly unstructured data around public health threats. And we, as earlier mentioned on the previous slide, both indicator and event-based surveillance form a critical part of the early warning functions. And next slide, please. So event-based surveillance has several steps. The first is signal detection, which mainly looks around, working with the different sources in detecting public health threats. And the second phase is reporting these public health threats to the next level. And then the next level now, triages. Triages just mean you're looking at the different events or different signals that have been detected according to the public health priorities. It doesn't form part of L1. It doesn't mean this information that you're picking actually is a priority as far as public health risk is concerned. So that is how you triage and pick events according to the importance, and also eliminating duplicates. Then the following steps around verification, and usually depending on the capacity at the different administrative levels, this is being assigned to the nearest stakeholder to the source of the information. And this is just a process of actually establishing validity of the information that has been received. And then finally, risk assessment. For the sake of time, I might not be able to go deeply into risk assessment, but it's just about prioritizing ranking the different events according to their severity and the impact on the public health. And then once that is done, then an alert can be sent out. Next slide, please. So now, why do we want to deploy One Health in event-based surveillance? Because as far as event-based surveillance is concerned, it's mainly supporting EWA. It doesn't help in strategic planning. It doesn't help to actually guide policies as the indicator-based would do. In event-based surveillance, the sole function of event-based surveillance is strictly to support early warning and response. So let's look at the next slide. So just consider a scenario where you have 5 herdsmen in a community that slaughtered a sick animal and both and all fell ill. Case 1, as you see, doesn't get medical help and dies at home. Case 2 goes to a clinician, say in a public facility. Case 3 goes to a local pharmacist and just gets medication for symptoms. Case 4 goes to a traditional healer, as it's the norm in Africa. And then case 5 goes to a private facility. And then you see all these different cases are within the same community. So as you can see, of the 5 cases in most of the member states currently, and most systems that are being institutionalized, only case 2 went to a clinician, which is part of the official reporting system of the country. And this is kind of 60% of all the cases and are being missed. This represents just 40%. The 2 that went to the clinician represent just 40% of the cases that are being picked by the conventional reporting system. And then imagine that 60% of all cases that are being are happening in the community are missed. Next slide, please. Now we are trying to translate that initial previous slide to kind of a demonstration here, and we just we're just considering that this could be like yellow fever, Rift Valley fever. Sorry, we all know how Rift Valley fever spreads, and this slide just shows us the cycle of the virus and the different interfaces. So we see that we have like 3 interfaces: the environmental, the animal, and the human. And this gives us like an opportunity to detect at these different interfaces. Next slide, please. So again, referring from the previous slide of the 3 interfaces, we know that using the One Health approach, there's a very great opportunity for us to detect from these different interfaces if early detection can be put in place. So if early detection systems, can be put in place. So as we can see, if you're using the One Health approach in detection, you're considering other line ministries like the animal sector, the environmental sector. You're scanning the media to look at reports from farmers. You're looking at reports from the veterinary clinicians. You're looking at reports from the facilities. You're looking at reports also from the research institutions and other field teams that are responding to public health threats. So we have a very huge opportunity to detect from these different sources, and also increases like the probability of actually detecting this public health threat earlier on before even the spill over to the human population. Next slide. So this slide shows us, next slide, please. Next slide. So, so this slide shows us how we can detect from these different sources that I just mentioned. So there's a vast opportunity if we employ the One Health approach to detect from, like I said, the media, the health facilities, and also the communities that are actually doing the work on the ground. So there's really a great opportunity in picking up public health threats way earlier and avoiding the spread or the spillover to the human population if measures are put in place. The One Health strategies are put in place. Next slide, please. So this is just to show us what an outbreak cycle would look like. If there's an outbreak, if nothing is done, you will still follow this cycle. But of course, it will either kill all the people in the community, or maybe at the end of the day, people get immunized and get some immunity to be able to overcome the threat. But however, if you look at day 3 on the graph, if there's early detection capacities and structures using the One Health approach, you see that the public health threat will be detected at day 3, and response could set in at, say, day 9. And then you see that there is a very great opportunity to prevent the spread of the disease in both the human population and the animal population. So you see the number of deaths and cases that will be averted will really be huge. And we're going to see that in the next slide, please. Next slide. So this slide just shows us now how that previous slide translates into the One Health approach scenario. So in the pink curve shows us the population in the wild animal species population. And then you see the light green curve that shows us, the light green section that shows us the domestic animal population, and then the blue now shows us the human. And like I earlier said, if there was a One Health approach in place, there's a great advantage of actually picking up this public health threat within the wild animal population before it spill over to the domestic and then further spill over to the human. So we can actually put in or join fees together to ensure that cases that are being reported, alerts that are being picked in the wild animal population are being sent also to the domestic animal populations, just so that to the animal sector, sorry, the domestic animal sector, just so that preventive measures are put in place earlier on, and also barrier measures just to prevent the spill over to the domestic and then further to the human population. Because of time, I might not be able to explain this in detail, but if you can see the darker green color, you see the control benefits to the domestic species. So you see that a huge number of animals would have been saved, and also you see the blue, you see the control benefits to the human population, and this is really, really what we are looking forward to having. Next slide, please.
Merci. You have 1 minute left. So please.
Thank you. So I'm concluding, and these are some of the recommended tools that we feel should be institutionalized to ensure that the One Health approach in early detection can be efficient and functional. So the first is establishing a technical working group for EBS, bringing together stakeholders from human, the animal, and the environmental population. Also identifying potential signal sources, and these signal sources should actually include sources within the animal, the environmental, and the human. And also a signal list that also takes into consideration animal, human, and environmental events. And also define communication architecture across the different sectors. The human health already has a very defined and structured architecture for reporting. The animal is struggling, but again, the environmental sector at the community level really lacks some sort of this architecture for reporting. And this is something that we want to look into and strengthen even better. Interoperable reporting tools. And we know that there's a lot of fragmented reporting, and there's need actually to interoperate and ensure that signals that are being picked within the human can be shared across with the animal and vice versa. Joint capacity programs, for instance, for on event-based surveillance, we have developed like a One Health event-based surveillance training module that supports us to train both the animal and the environmental and human surveillance officers together. Last slide, please. So this last slide just shows us an example of some of the work we have been doing. This is what we just did a few weeks ago with Uganda, establishing One Health event-based surveillance information sharing architecture. And this is something that we really want to build on as a best practice for other countries to incorporate. And we are not only doing this for the architecture, but we're also looking at the different reporting tools and looking at opportunities and ways of creating that interoperability at all the levels of the health system to ensure that detection and reporting is connected across sectors. Thank you so much. And I'm sorry for crossing over the time. Hopefully we'll get questions later. Thank you.
Thank you, Mercy. Thanks so much. So I will keep encouraging participants to post questions. As I say, we will go through all the presentations and then we will have the Q&A session at the end. So thank you so much. Next speaker is Andrea Capobianco. He's a veterinary epidemiologist with over 15 years of experience as a wildlife veterinarian, both in the field and in a diagnostic lab. He currently works as Global Early Warning System Coordinator for FAO, leading the activities on disease monitoring, analysis, and forecasting to ensure early warning and early action for transboundary disease threats. Over the years, Andrea gained considerable experience in the designing, development, and management of animal health information system and the application of new technologies, including artificial intelligence, to the public health sector. So please, Andrea, the floor is yours.
Thank you very much, Laura. Let me share the screen. And I want to thank all the participants and organizers for the opportunity of being here. Can you confirm you can see my screen now? Okay. Can you see my screen? Can I start?
Yes.
Yeah.
Okay, great. Good morning, everybody. I want first to start with presenting what is the mandate of the FAO Animal Health Service, because FAO works with countries to develop capacity to prevent, detect, and response, as well as to recover from high-impact animal diseases, including zoonosis and any other threats of animal origin. All these actions are keys to fight hunger, malnutrition, and poverty. Within the animal health services, we have a disease intelligence workflow that we implement on a routine base, on a daily basis. So we have a detection procedures that happens from collecting information from the field. This information comes either from decentralized offices or other international organizations, but we also use disease intelligence tools that have been developed by other organizations like EIOS from WHO. These information are then verified at that quarter level, at the central level, and then they go through an analysis process and they are used wherever is necessary and possible for assessment and forecasting. And this information are then disseminated through real-time alerts, weekly updates, or like monthly, quarterly updates. We mainly monitor TADS, transboundary animal diseases, but whenever is necessary, wherever is possible, we also monitor any other threat that is of relevance for veterinary public health and public health in general. The core of our system and our workflow is EMPRESS-I Plus, that is the Global Animal Disease Information System. This has recently been updated. It was first launched in 2004, mainly to monitor avian influenza. The system allows data entry from different devices, either manual entry through automated data upload or through mobile application that allows to collect information from the field. The information are then stored and verified and stored into EMPRESS-I. And EMPRESS-I has both a public interface and a private interface that allows the general public to access all the public information that are not confidential at any way, and then to store confidential information for private access to either the countries or FAO personnel that allows to do further analysis on this information. EMPRESS-I has recently, as I was saying, undergone improvements and has been integrated with Hand-in-Hand. Hand-in-Hand is a GIS tool developed by FAO, where all the information are integrated and displayed on a maps, and then there are different databases that are integrated into Hand-in-Hand to allow the display of information of the different sources to the general public. As I was mentioning earlier, the information from the field are not coming just from reports from our colleagues in the countries, but we developed a mobile application that is called MI that allows real-time disease reporting. This facilitates quality real-time reporting of animal disease from the fields, and there is a process of validation of this information along the entire chain by different degrees and authorized person within the veterinary services. This improves communication among the veterinary services and the animal health workers at country level. Data can be collected also offline, but of course they need to be online to be shared with EMPRESS-I. And then once they are sent through a secure channel to EMPRESS-I, they are stored in the cloud. These are the information that the countries, when they can validate and they can decide to keep confidential if they don't want to share with the general public. Within the tools that FAO has developed, there is also CLab for Africa, that is a laboratory information management system. It's been implemented in over 12 countries in Africa, and it's currently discussion with the other countries in Africa and now also in Asia. It allows the standardization of laboratory diagnostic process, as well as sample traceability and the management of information within the veterinary laboratories. CLab for Africa is very important because it's one of the tools, part of the early warning activities that allows to collect information not only from the field, but also from the labs. And it's integrated into MPrecise, so some information according to the confidentiality and the agreement with the countries flowed already into MPrecise. Then from a forecasting perspective, we developed also some specific tool starting from Rift Valley fever. We are working on one for avian influenza. We developed the Rift Valley fever early warning decision support tool. It allows the real monitoring and risk forecasting for Rift Valley fever, and develops maps and assessment to guide informed early action for prevention and control. Of course, the decision support tool identifies climatic anomalies to forecast areas at risk of Rift Valley vector amplification. This gives the power and the time to the national authorities to implement early warning activities at national level, as well as to early detect any possible outbreaks, either in animals or in humans. It is integrated with end-in-end, and as I was saying before, it facilitates real-time data sharing and consultation among experts. These curves have already been explained several times, but the benefit of having a forecasting tool, so alerts, it allows anticipatory actions for risk prevention, and then in case countermeasures are implemented as early as possible, the risk and the that you develop a very bad situation is much lower than expected. Then FAO doesn't only work alone, but we obviously work with the other international organization. They used to be just a tripartite. Now it's recently become quadripartite because UNEP, the environmental agencies of the United Nations, has also joined these activities. But anyway, at the moment, we can still talk about GLUS Plus as a tripartite, means FAO, OIE, WHO initiative. It's been established in 2006 and it allows to share health threats information across the 3 different organizations, including zoonotic disease outbreak. We share epidemiological data and risk analysis. We conduct rapid risk assessments as well. We have done for SARS-CoV-2 in 2021 and Japanese encephalitis in 2022. And we deliver early warning messages on areas at risk, every organization through its own country offices and its own connection. But of course, we communicate to our member countries because those are our stakeholders. And it combines official reporting data, rumor tracking, and trends analysis. But we do not only do this alone. The 3 organizations, Tripartite Plus as well, only FAO, we also do research work and risk assessments on a country base. And this initiative allows to the research work and risk assessment to provide recommendation on many emerging threats. This is very, very important, especially for the countries. So MPrecise Plus is aiming for a One Health intelligence that can provide better production. So it's been improved, implemented, and updated, thinking to become a One Health data platform to integrate and analyze data from multiple sectors. So FAO not only deals with livestock and animal health, but we have all sorts of data coming from aquaculture, crops, environment, and all these information are aimed at having an holistic approach to early warning for something that is not just public health, but is One Health from the broadest possible perspective that we can see.
You have 1 minute left.
I'm done. Last slide.
Great.
This is what FAO and EMPRESISE foresee for the future. There are many open questions about global One Health intelligence and early warning, because there are many potential opportunities that still needs to be identified, and it's necessary to see how we can strengthen One Health intelligence. Of course, there are many challenges still to how to integrate information across sectors, especially to develop immediate real-time risk assessments, as well as to implement anticipatory reaction. And the biggest challenge that everybody is facing, how to ensure resources to all these activities. The way forward that the quadripartite has already started is developing an early warning framework through the One Health Intelligence Scoping Study. That is an initiative proposed by the G7 and funded by the UK government. And of course, there is risk reduction at the human-animal ecosystem interface and the FAO strategy framework that FAO has been working on together with the other organizations. Thank you very much, and look forward for your questions.
Thank you very much, Andrea. I see that there are already some questions popping up in the Q&A, so please keep the woodwork there, and we will come back to those at the end of the session. So our next speaker is Mwangi. He's an infectious disease epidemiologist leading research on prevention and control of zoonosis in East Africa, and more broadly, the interventions that improve animal health and production and human health and nutrition. He's an associate professor at the Paul G. Allen School for Global Health at Washington State University, Chancellor's Fellow in Global Health at University of Edinburgh, and co-director of the Center for Epidemiological Modeling and Analysis at the University of Nairobi. So please, Mwangi, the floor is yours.
Hi, Mwangi. We can see the presenter view. Can you change to full screen, please? Excellent,
No?
thank you. Yes.
Okay. All right, so I'll start. I'd like to speak about surveillance for detection of animal and zoonotic diseases. Part of the work that we have done for a number of years, particularly here in East Africa. And I've borrowed a slide here from Jacob, who will be speaking later, that looks at a schematic relationship of the time to detection of an emerging pathogen and its cumulative cost of control. I think what to look out for is this big dark line here, that if you can detect diseases before they go to humans, then the cost of control is actually quite less compared to if humans have been affected. So I would like to summarize some work we've done, particularly on human and animal syndromic surveillance and the use of mobile phones to assist reporting, particularly from the community. And then finalize with some work on digital biosurveillance, where we have used internet-based information to see whether we can improve our reporting for zoonotic diseases within animals. So in a summary, we have some data for about 6 years, beginning 2013 to 2018, of about 1,800 households in Western Kenya that we followed every 2 weeks and conducted, administered a questionnaire to household members every 2 weeks for a period of about 6 years. But also allowed the community or the farmers to report infectious diseases or events that happen within their farms through a mobile phone. Basically, not a smartphone, just is a toll-free number that they are given, and they can make a call and report any kind of disease event that they see in their community. And then the response to those reports is to send in a team of animal health assistants who go and do the examination and, where possible, treat the animals. So out of that work, we noted really interesting things. One is when you compare reports that come to the to the study or come to the the veterinarians through household interviews that are conducted bi-weekly, and those that come through a toll-free number that is the farmers can call, we found that over time, the farmers really adopted the toll-free number, and most of the reports were coming from the toll-free number compared to the usual household visits. But importantly, we saw there was a big difference actually for the validity of a case, whether is it once you go in and ask, you reported you have a diarrhea, and they can do an examination and find out if the animal was actually diarrheaing or not. We see that the odds of a valid report coming through a toll-free number or a toll-free call was actually quite high compared to reports that were from routine household visits. So it's not just the validity of the reports, but also showing that we were not, by using a toll-free number, you are not spending as much energy and as much money, but you're getting really good results, which I thought was really interesting. But what was even more interesting was the use of a toll-free to report disease is not associated with whether or not you own a phone. And this is rural Western Kenya. And I think that's a really important finding because phone ownership across many parts of the continent is actually quite high. So a farmer need not even own a phone for them to be able to access a phone and make a report of a case. So that we thought was really interesting, but also that, you know, people with a few more animals, they have a higher likelihood of reporting through this kind of toll-free calls. But the final part that I wanted to highlight in this discussion is what is it that farmers would want to report through the mobile phone toll-free numbers. So they would report illness and they would also report death. But what we found is that for illness, the likelihood of a report coming through the phone was greater than the household visits compared to death. And I think that's a really important thing to have in mind, because if you are interested in a disease that manifests mainly in death and you are depending on community reporting, you might not get those cases quite easily. The sensitivity for that is not great. But also the other really important thing that we found out of it is that for syndromes that manifest severely or more dramatically, those are the ones that they are likely to call for. And then that does not, manifest dramatically, like a skin condition, they are not keen to call through that method. So in summary for that, the phone-based animal health surveillance system, we found it's a really effective tool for reporting disease event by communities. That widespread phone ownership or phone access means that you need not worry about reporting bias. But importantly, there was greater propensity of using phone-based systems for reporting illness, especially for those presenting with severe clinical signs compared to something like death. Which means if you were to interpret that, for sensitive diseases, this method is sensitive for diseases like rabies and RVF, but may not be sensitive for those just present with death without prior clinical signs like what you'd see with poultry. The second part of my talk was to just present some other work we have done looking at a comparison of what would internet event-based biosurveillance tell us about the potential for digital biosurveillance in the early detection and warning of, and we have selected the top 5 zoonotic diseases in Kenya, which are rabies, anthrax, trypanosomiasis, brucellosis, and Rift Valley fever. And so what we did was use a tool we call BioFits that is able to harvest digital articles for a period of 2016-2020, and then we conducted some analysis to identify what would be a unique disease event by location, date of occurrence, and additional epidemiological indicators. And then we compared what was happening with the reports that came from newspapers compared to what was seen in the official reporting systems as the national and international health agencies. So the key findings from that was we had more than 400 unique disease events that were reported over that period of time. But we found for the top zoonotic diseases, Rift Valley fever was quite well reported, so was anthrax and a little bit of rabies, but there are really no cases that were being reported of brucellosis and trypanosomiasis by those non-traditional sources of information. The other really important finding is that most of the disease events were first reported by the news media and then followed by other official health agencies. But importantly, we could detect from our data that news media were reporting events up to 4 days before other sources could report. But importantly, we found that livestock-related outbreaks are significantly more likely to be officially reported compared to those in humans. And also, if we made a comparison between, say, Rift Valley fever and anthrax, RVF was very well reported officially, and not very well reported from the news events. And the conclusion from that is that our understanding is that there is a little bit more local and global attention that's given to certain zoonotic diseases. For instance, Rift Valley fever. Whenever a case is detected, there is obviously active investigations and official reporting of the disease. And that's why we see a little bit of that being reported better officially and not in the news. But for diseases like brucellosis and trypanosomiasis, which are difficult to make a diagnosis for clinically, those were rarely captured or were actually not reported by the news agencies. Because it's difficult to make that diagnosis in the absence of laboratory help. And non-traditional sources of surveillance data, I think, would give a significant lead to outbreaks in the community ahead of official reporting. And this, to me, integrating this community-level disease reporting, like the toll-free number that I talked of, and these internet-based events for biosurveillance, I think they have big potential for improving early detection and response. Many thanks.
Thank you so much for that really nice presentation and also sticking to the time. So let's we'll put the video again. So let's start with the Q&A session. And sorry, it seems I cannot turn my video on because I've been stopped by the host. So I will kindly ask Mercedes now. Great.
Yeah.
Thanks a lot. So unfortunately, we have a bit less of time, but there's still a lot of really interesting questions coming up. So my first question is for Mercy, and it's about interoperability of data coming from human, animal, and environment, in the sense that the diseases for each of these areas may have different indicators. So how do you deal with having this type of variety when putting it together?
Thank you so much. I think that's a very important question. But to start with, event-based surveillance does not actually work with indicators. So event-based surveillance makes use of signal reporting, and it's mostly unstructured data that's streaming in. However, that is one of the reasons why we say to get started, you need to have like a functional event-based surveillance technical working group that takes into consideration the different sectors and the different sector needs and harmonized approach in the data sharing. So what I mean by bringing these different sectors together is there need to be a list of signals, of priority signals, and these signals definitely cut across different sectors. So if you're looking at zoonotic diseases, you're looking at environmental events, you're looking at maybe some events that maybe could be detected by just the animal sector, but has a bearing on the public health population as well, the human health, sorry. So that has to be institutionalized. Those signal lists has to be developed by the technical working group. Before you talk about even ensuring interoperability, they have to agree on what they have to report to start with. And then the tools that have to be, that is being used. The human health has like so many applications at the community level in most countries. And in some countries too, the animal health also are far advanced with some digital tools that are supporting their reporting. So when they already have like these signals that they want to report, of course, that's when we can start talking about how do we ensure that at the different levels where these signals are being detected, this information can be shared. And that comes now to ensuring interoperability within the different digital applications that are being used. For countries that don't have the One Health approach, or they don't have the One Health technical working group, this could be a way to go with. For instance, in Uganda, they have actually agreed to have like a system, a centralized system where both the animal, the human health, the environmental health can have access to these platforms and submit their data. Or if there are already existing systems, then there's no need to sweep them under the carpet, but just rather ensure that data streams from these different applications into decentralized systems that can be accessed by both sectors. So that's how I would want to answer, and ready to give more light should there be need.
Thanks a lot. That was really, really useful. So I'm going to move to next question. Sorry, just bear with me a second. There are really a lot of them and it's not easy to choose. So that would be for Andrea, and it's about evaluation of the EmpressI in the sense if it has demonstrated usefulness to reduce the risk of a disease incidence, and if so, if you may have any example or practical example to explain. Thanks.
Thank you very much, Laura, and thank you for the question. EmpressI is at the moment mainly storaging and allowing to display on a map and analyze disease events. EmpressI itself alone, it's not enough at the moment, although we are working on expanding the features of EmpressI. And this is why we have all these other activities that work together jointly with EmpressI. We analyze the data on EmpressI with other tools like we do for Rift Valley with the decision support tool. And those are very, very useful for forecasting with a few weeks of advance the possible outbreaks of outbreaks, vector amplification at risk for Rift Valley hotspots. And that on EmpressI allows to develop risk assessments. So these are very important. So EmpressI itself, it's just one of the tools. It's the core of the system. And we are moving, FAO is moving toward integrating all these other tools that were born separately, and they are coming together into one system. There are plans to integrate and make EmpressI interoperable with WISE, but these efforts are joint efforts between the different organizations, and this is not very, very easy. The One Health Intelligence Scoping Study that is at the moment undergoing by the FOR organization is aiming just at this, developing a One Health framework, intelligence framework, and possibly bringing together the different system between the different organizations. For now, at the international level, possibly going down to the up to the national level to allow better early warning, better reaction, and better response. I hope I answered to the question.
Thanks. Yes, it was quite insightful. So we'll move to the next question. So let me just go back. I think I remember anyway. That would be for Mwangi. Was about if there's any information available of this reporting system from the phone on the literacy of the people reporting that information. Thank you.
Thank you. So we used a very basic connection with the farmers. We did not expect them to type anything. All they needed was take up the phone and make a call and say my animal is unwell, and the person on the other line could speak even the local languages. And then there's a response, at which point the animal health assistants and veterinarians can make a decision as to what is ailing the animal and even provide treatment. So literacy was not a big issue really for this kind of surveillance.
Thank you so much. I saw different questions coming in the Q&A that I would like to ask to the full panel here about the role of different professionals. They mentioned lab professionals, anthropologists, and how to set up a One Health system. So what would be the first steps? I would like to see the views from the three speakers. I don't know if someone wants to start.
If you want, I can start, Laura.
Please go ahead.
Okay, it's not easy to set up a One Health system. Of course, there are very many differences if you are talking of country level, regional or international level. At country level, of course, developing, as Mercy was showing, communication and relationship between the different ministry and the people working from the field to the central level is crucial, but it will be necessary to understand what are the basic information that you want to report, who is collecting, who has access to this information, and how this information are shared along the different levels within the country. Then if we come to the international level, things get a bit more complicated, and the accuracy of the granularity of information we have from the fields become less strong and less precise, but it will still be important to start from national all the way to the international level to develop something that is significant.
Thank you. Something to add, Mercy Mwangi?
I think Dr. Andrea just captured everything. It's kind of very complex to actually respond to that. But taking it from the event-based surveillance lens, the national level, we are talking about the different sectors. And within the different sectors, we have like different core capacities and core competencies that actually are very, very critical. And within the event-based surveillance sphere, we have like the 4 different types. And I think Dr. Mwangi had mentioned like the toll-free, which falls within the hotline. And usually we are recommending that we have like a multidisciplinary team that supports the risk assessment at the lower level. So even if you receive like the calls, it will definitely go back to district level where risk assessment has to be done. And depending on the kind of event that has been captured, this team is being composed. And usually the anthropologists, you bring together the laboratory, you bring together, and if it's kind of a zoonotic event, then you're bringing in maybe a laboratory scientist from both sectors. So you see, it kind of fits as you get into the actual work. So, and again, just to reiterate that for the event-based surveillance space, or we have the different types, and health facility is also one of them. So for the health facility, we don't limit only to the hospitals. We're also looking at the vet clinics. We are looking at the laboratory, because these are all structures that help in early detection. So we're not only looking at the laboratory from the human side, we're also looking at the vet lab. So it kind of, intertwines as you get to look at the functionality of the early warning and response system. So all those different core competencies just fit within the functions. Over.
Thank you, indeed. Something to add, Mwangi?
Yeah, just a quick one. What I was presenting is out of a theoretical thinking that you can actually improve detection of say, infectious diseases at a community level using simple methods. But the results we get is we fully don't understand why, for instance, people are willing to report illness and care less for reporting death. Maybe because veterinarians haven't known how to raise the dead. But I imagine that the help of anthropologists would actually really help, have an understanding of what would work and what would not, and importantly, why that is not working or why something is working. And I feel that's sort of a really big component that we haven't incorporated. But it's not just in the detection, but it's also even in the responses and even in behavior change, which means it's not just a medical person, a veterinarian who is able to do that. So I do feel there is really room for a lot more engagement in a holistic response of infectious diseases within our communities.
Thank you so much. And I would like to wrap up this session on those lines. One Health, I think for all of us, at the end, we need any possible expertise. And as we go, we may even find new ones that are really useful that haven't been added so far. So maybe the answer to whom to add, I would say anyone that is willing to help. So there are still some questions on the chat that unfortunately we will not be able to answer live, but I encourage the speakers, if you can have a look at the chat and answers those if you have a bit of time. I'm sure the attendees would be really grateful. And I would like to close this session first thanking all the speakers for really, really nice presentations, overviews, and your thoughts around this, the attendees for this session, and also the organizers. So back to you, Osman.
Thank you, Laura, and thanks for keeping us to time and for chairing such an excellent session. I think we've really got our participants thinking, and I see that we've the workshop's going well because we've had very good retention from yesterday. So everyone decided to come back for the second day. So we're doing well. So thank you again to all our speakers, and we're very grateful for the time you take to present your research and and share your expertise, because we know you guys are not, well, you're not being paid or anything for this, so we're very grateful for the time and effort that you put into provide all this experience and expertise to all our participants across Africa and more widely as well, because we have people joining from Asia and from Europe as well. So moving on to the next session then. Who do we have? This is also, I'm really pleased about this next session. We're going to be talking a bit about syndromic surveillance as a tool to strengthen and augment conventional surveillance in Africa. And I'm really delighted to be able to have Dr. Salome Bukachi join us. Salome is a social medical anthropologist with vast experience on infectious diseases, with a focus on zoonotic diseases, gender issues, nutrition, anthropology, health systems, socioeconomic and cultural behavioral aspects of infectious diseases and development. She currently lectures in anthropology at the University of Nairobi. She is a member and a working group co-chair of the One Health high-level expert panel. So we're really lucky and delighted to be able to have Dr. Bukachi join us, and I'm sure she'll mention the key, very important key elements around behavioral research and the social research dimensions, the anthropological dimensions of research that's necessary to support the outbreak response process and the surveillance aspect of disease control as well. So over to Salome.